So what are some of these persistent challenges I'm mentioning? So the first is the question of how do you understand the problem that we're talking about? So inherent in a definition of, inequity or equity is a comparison. And so part of the question is when do you compare, when do you not compare, and what is the value of doing that kind of comparison? What it doesn't tell you is that it doesn't tell you what's unique about the population that you're talking about. What are the determinants of the poor health of the group that's doing worse? It helps you to identify some of these key things, but it doesn't also tell you the third point here, the assets or source of strengths from the community or from the population of interest, or the historical social context that are relevant to the initial existence of a disparity or of a difference. What are the things that are culturally consistent with the ways that we think about why a problem exists and what's actually true? So we're looking at racism as a systemic factor. The second part is that racism is based on an ideology of inferiority. The key part of inferiority, it assumes that there's really not much you can do to address or improve the lot of the group that is doing worse versus something like race versus, say, ethnicity. Ethnicity suggests that there are things you can do to educate, expose, socialize people, to give them opportunities to look at those differences and close those gaps. When you talk about the fundamental inferiority of people who are defined in lower ranks of things like race, we're talking about a different way of thinking about it that doesn't suggest that there's really much value in actually investing in those groups. And that definition drives how we potentially allocate resources that have important implications for health and well-being. What we're saying here is that you have to understand that most of the interventions and strategies that we're doing are not really designed to deal with the social determinants of health. One of the things I want to say is I know that what we're asking in terms of the way that you shift your thinking to do and to center health equity science is difficult. What I've asked of you in terms of all this anti-racism stuff is a lot. And I know that one of the things that is difficult is how do you actually stimulate this new thinking? You're trying to disrupt old ways of thinking. You're trying to inspire new ways of working together, new insights to guide your work, inform new strategies, and work with new people that you may not have collaborated with before. So this last section is really about what are some remaining questions, issues, and opportunities that we have to grapple with? I've used the analogy that since we've never achieved health equity, um, and that this has been a persistent problem in our society since we've had a society and even before, I've used the analogy that we're essentially trying to reach a destination. It's one thing when you're trying to return to a destination you've actually been to, but when you're going to something that nobody has seen before, they can't guide you where to go. One of the big challenges with that is the way that we've tried to approach this problem within the structure that we've set thus far. We've tried to achieve equity in specific areas of health without necessarily recognizing how do we actually achieve equity in prostate cancer if we don't achieve equity in life expectancy.
Here I want to make note though that, when you are adjusting for these factors in a model, you are probably underestimating to some degree the real impact of racism, because we know that racism shapes things like racial residential segregation, things like education and poverty. In the final model, we adjusted for white mortality rates. So when you do this, you are controlling for other unmeasured factors that might influence overall mortality in a geographic area. You're also now starting to tap into disparity.
So one thing I just kind of want to name before we talk about kind of solutions and moving into that is what is unhelpful when it comes to health disparities research, things that I hope we can start to move away from. So one thing that is unhelpful is quantifying health disparities. I think that there is a preponderance at this point of data showing that we have a huge problem with racial health disparities in this country, and spending more resources on these kinds of studies doesn't actually do anything at this point to change the problem. I think another unhelpful line of research is research that kind of perpetuates myths of racial biology. There is no consistent genetics, for instance, that every single Black person has. And furthermore, racial groups are also false and misleading because with increasing understanding of people's DNA ancestry, we understand that there are very few people who have like racially pure ancestry. And so what do we do with that when people are made up of many racial groups? How do you racially categorize them or do race-based medicine? And I know that within the institution, this isn't easy, but it doesn't mean that we shouldn't be trying to constantly think about this and push the boundaries in this regard. And so when we put all four of these components together, what we have basically is the racism as the root cause approach. I recognize that not everybody is going to be in a position to be able to do all four components all the time. But what I would offer is that, doing two components of the four is better than doing none. So even if you can only integrate one, that's better than doing none.